Okay.
It's fine. Okay, so welcome everybody. We have Dr. Heather Jeffcoat. She is on Instagram as the Lady Parts PT, and we are talking about sex without pain today. So, Dr. Jeffcoat, thank you for carving out time in your day, and please give us a little bit of an introduction for yourself.
Yes, so thank you so much for having me on here, Janice. This is awesome. Our part 2, since our first one, we lost.
We lost. That was so painful. So if you're
painful.
watching this, you probably want to know what happened. But basically, I don't know what happened, but the people that I have helping me with recording, somehow the recording just got lost.
So I am the owner of Femina PT, Femina Physical Therapy in Los Angeles. I have 3 offices. I have 3 offices in the Los Angeles area, I should say. And I also do telehealth coaching for people that have questions, usually around my book, Sex Without Pain, a self-treatment guide to the sex life you deserve. That is the majority of what we see in my practice is chronic pain, chronic pelvic pain, and sexual dysfunction, sprinkled in with a little bit of incontinence, no pun intended on the sprinkle, but we do see that, and we see pregnant ladies and, orthopedic dysfunctions. And I just see a ton of, I've had so many pregnant women lately that I think are just getting more aware of not normalizing their postpartum conditions, and they really they're 9 months postpartum and they feel like they're falling apart. Like it started with their feet hurting in pregnancy with the weight gain and getting plantar fasciitis, and then their knees, and then their hips, and then they have incontinence, and then
they couldn't exercise,
and then their shoulder starts to hurt, and then it's just like a whole. I mean, we started putting all our postpartum patients in 90-minute sessions. I used to think they were a lot more straightforward than they really are. And most of our evaluations are 90 minutes. Follow-ups, for the most part, are 60, but sometimes they go up to 2 hours when I have a patient that's as complicated as that one, because it's just too much to manage. And
because you have a plan of care for each thing.
Exactly. It's like 8 different plans of care that we're trying to manage. And I love what I do. It's been a great sort of experience in our office, and I have it set up to provide the patients the care that they need, not having insurance dictate what they think patients should have. So I am also an out-of-network provider, because I think we just see too many complicated people that don't fit into a 20-minute PT visit box. So that's a little bit about my practice.
Excellent.
And I do specialize in pelvic health. However, I do call myself an orthopedic therapist with a subspecialty in pelvic health, because of all the things I rattled off. Our pain patients, our pelvic pain patients, are really orthopedic patients. They have a lot of things that are potentially driving their pain. And so I do still keep up on my orthopedic skills and my other manual skills and treatment skills.
Very important.
That. Yeah. So that's sort of my big push for pelvic health PTs, to get more orthopedic training, because our patients really need it.
Yeah. It's not, the pelvic floor attaches to the skeleton, to the pelvis.
Right. It does not live
it's not
in
just the pelvic floor.
Yes, it's not a silo.
And it has nerves and blood flow and hormones and so many things that affect it. So,
yeah, exactly.
Good. All right. So we're just going to jump into some questions here. I have a list of 10 questions, and then we have some audience questions. So we'll get through as many as we can. Tell me, in terms of timing, do you need to finish right at 30 after, or what is
no, I have more than 30 minutes.
Okay.
Yeah, I can go 45 if you need
Okay,
to.
good deal. All right. So how common is painful sex in women?
So I used to think it was about 1 in 2 women. That's what a lot of research had been published as far as sexual dysfunction. There was a study that's still quoted a lot that says 43% of women experience sexual dysfunction at some point in their lives. And then only a portion of that was pain, right? So I would see articles that said vulvodynia at 24% and vaginismus anywhere from 2 to 12%, and all these numbers all over the place with painful sex. But then ACOG came out in a position statement, and they said that 3 out of 4 women experience painful sex at some point in their lives. And I'm still kind of looking for that primary study that says
where did they get that number from?
But that's on ACOG's site, so I do quote it, even though I don't have the primary research for that. So 75% of women, and then yet so many doctors even so will tell me how, I don't really send you anybody, because my patients don't really have that problem. Like,
have you asked?
You must be so lucky to get your entire practice be made up of the other 25%. Like you're really doing something
very,
right
very
there.
random, right? Not. So, okay. So it's very common, 3 out of 4 women. Are there other types of sexual dysfunction other than pain?
Yes. So a lot of times people think, okay, well, I don't have pain during sex. I actually have pain after sex. So is that relevant to me to still come to PT? And I would say yes, because there are many reasons that people can experience pain after sex and not during sex. And it still could be musculoskeletal in nature. So, obviously patients would need to be cleared for like sexually transmitted infections, urinary tract infections, make sure they don't have any other organic cause of their pain, like a cyst or something like that. But if all of that is clear and you continue to experience pain after sex, then what else could be going on? What else is in that area? So yeah, you have muscles in that area, you have nerves. Could there be some like overstretching of the muscles that's occurring? So while intercourse itself is not painful, when you have prolonged stretch, or maybe too rough of sex and there's like a lot of stretching and friction, maybe you're not well lubricated, there can be some like muscle rebounding or muscle tension that occurs after. Or if you're like slightly overactive and you get a lot of like prolonged stretch, then again, like getting that rebound effect, and that can cause, feelings like you have a urinary tract infection or a UTI. So women will say, if I don't have I don't have painful sex, but I feel like I have a UTI for like 48 to 72 hours after I have sex. So they avoid sex, not because sex hurts, but because sex hurt, post-sex hurts, post-coitus. So that would be, one type of sexual dysfunction I would still classify because it's related to intercourse. Also treating women that have reduced capacity to orgasm, especially when they've noticed like changes over time. Like I used to have good orgasms and now they're just not as intense as they used to be. And so, evaluating them and see what could be driving that. Sometimes it's pain. They just say, oh, my orgasms aren't as good as they used to be, but they have pain. So their pain is inhibiting their pleasure, or maybe their muscles have just gotten weak over time and they just need to do like a basic strengthening program. Maybe they thought they were doing Kegels right and they weren't, so they weren't getting stronger. So those could be other types of sexual dysfunction that we see often enough in our office. Well, I would say probably not often enough.
Right. They're not talking about it. Yeah.
Yeah. In my practice, I do see it, but I feel like these things are way more common than they're reported. So women need to know that there are options for that.
And then also like orthopedic. So like if they have pubic bone pain, that can cause pain during sex. If they have tailbone pain, hip pain,
back
right?
pain, right? I was not thinking beyond.
No, you're good. You're good. I just wanted to interject that. So
yeah, because and what modifications can be made. So we'll go over that if they're having like hip impingement, like recommending positions for them, maybe getting like wedges, like introducing tools that they can use.
Be creative.
To be creative, exactly.
Yes. I loved your story because you've gone to several, I think, conventions or like sex toy related things. And so you'll post different things. And I love seeing the options. And you're out there in Southern California, so you have all kinds of conventions probably coming your way. So keep posting them. It gives us ideas and we love to see what's new and fresh out there.
Yeah, that sex toy convention is not far from my house, and it's twice a year. And I've been invited to go back to it in January, so I'll be posting some more stuff.
Okay, we'll be looking for those new toys in January. All right. So how common is it to have pain after delivery?
So after delivery is probably one of the most common times to have it. And there was a huge study actually that was done in 3 years ago, maybe now, 1,200 women out of Australia. And it surveyed them and said, on your first contact, how many of you have painful sex? And then kind of at different time points along the way, as late as 18 months postpartum. Yeah. So 89% of women reported that they had pain on their first contact after delivery, 89%. And then when they followed them out, and I should say that 6 weeks or 6 months. So it was kind of insignificant in between. 18 months later, almost a quarter of them were having ongoing painful sex. Almost a quarter. And, a lot of them had stopped breastfeeding by then. So, there's often this dismissal in the medical community of
you're breastfeeding.
Exactly. Just wait until you're done breastfeeding. It'll get better. And a couple notes on that. One, I think, the reason why they have pain, barring any sort of like musculoskeletal issue, specifically scar tissue, whatever, if you're just looking at the vaginal mucosa, it gets dehydrated. Like you don't lubricate as well. You have lower estrogen, and that's one of the functions of estrogen, is to provide lubrication to our vagina. So there will be more friction and possibly pain. And then if you're not using lubricant because you're just expecting things to be the way they were, and especially if they had a C-section that was elective, like they just think, everything's going to be
hey, my vagina is fine.
My vagina's fine. I preserved it. Like, it's all good. And then they're really surprised when they have pain. And that study did say that women that had elective and emergent C-sections, as well as those that had traumatic vaginal deliveries, which would, in that particular study was vacuum assisted, that they actually had a higher report of painful sex than those that had a natural, spontaneous, uncomplicated vaginal delivery. Mm-hmm. So yeah, my C-section patients get really confused. They're like, I don't get it.
Yeah, like, hey, my pelvic floor should be fine.
Right. And regardless of how you deliver, your body still goes through those hormonal changes. And if you're not given the expectation that you're not going to lubricate as well on your own, and therefore you grab the lube, so you're just thinking things are going to be the same, then it's probably going to hurt. And, the study, almost 90% of women having pain, I think, highlights that pretty well.
Right.
Yeah.
And your pelvic floor still was carrying a baby for 9 months, so you have this support function, and think about all that it had to do there. What are your I have a dilator in my hand, and I speak with my hands a lot. I feel like a choir director. So what are your thoughts on topical estrogen during breastfeeding?
Well, my thoughts, not being a physician, I think that, that's sort of individual for the patients too. Some of them worry, especially if they have like personal history or family history of breast cancer or ovarian cancer. So that's all something that patients should discuss with their physician. Yeah, but I do have many women that do that, and it does help improve that complaint. And they know it's only temporary. Once they, a few months after they stop breastfeeding, they'll be able to get off of that sort of supplement. So, so that would be sort of a
possible option. And check with your provider. And for sure, lubricant. And also understanding that you're not alone. So 89% of people.
Yeah, 89% on their first contact. So you really do need to go in with the expectation of it, but how can you reduce that discomfort your first time? Because it's not good to just avoid it, because it will hurt, and once it does hurt, it's not good to continue to avoid it. That's not good for your relationship. And how our bodies work, as you know, like once they experience pain, muscles start to guard. So what becomes, and you get anxious and you get fear. And so once you experience pain, then you're likely to avoid it because you're expecting that it's going to hurt again. And it's like this self-fulfilling prophecy. You're expecting it hurts, so it obviously hurts. And, that starts to become a musculoskeletal issue. So that's why I think after 18 months that it still is painful for 1 in 4 women, according to that study, because it's no longer a hormonal issue. It started off that way, but now it's a musculoskeletal issue. And then the other thing, going back to that comment of doctors saying, when you're done breastfeeding, you'll be good. I've seen so many women that are actively breastfeeding and coming in for painful sex, and we get them pain-free. So if breastfeeding was the cause of their pain and they're still breastfeeding and now they're pain-free, then clearly breastfeeding is not the cause of their pain.
Exactly. I love that. Yes. I mean, it's such a simple concept, but to articulate it is huge and empowering. Okay. So breastfeeding does not cause painful sex.
It can be maybe the initial trigger, but it's not why your pain persists, would be the thing to say. Because yes, I think if they didn't go through those hormonal changes and they had an elective C-section, then maybe it would all be the same, but that's just not how our bodies work. So and then there's that whole wait and see approach too, which it happens with breastfeeding, but also I'm sorry, with painful sex in breastfeeding, but also incontinence and breastfeeding. Like everything is like, well, it'll get better. Just wait and see. And research doesn't support the wait and see approach. You know, women that report urinary incontinence at 3 months are still reporting urinary incontinence at 5 years postpartum. So I'm always like, how long are you going to wait and see? Like 5 years is a really long time after your last baby. It's just not going to go away. And a lot of times it progressively worsens, right? You see that clinically.
Yeah.
That it just is gradually worsens over time. So these women.
And panty liner turns into a pad, turns into a maxi pad, and so forth.
Yeah. It turns into like weight gain because they can't exercise because they're peeing their pants so much. And you know, it affects intimacy because they're afraid of smells. I mean, it just affects every part of their life. So these women need early postpartum intervention. And of course, every woman should get at least 3 postpartum PT visits. Like whether or not insurance covers it, I think they need to view it as just a service that they do for themselves. Like they go and they join exercise classes to try to get their body back. They might like, you know, do lactation consulting, which some insurance doesn't reimburse very well for. You know, they do all these other out-of-pocket things that they expect to pay out of pocket. I think there just maybe should be an expectation to just carve out the funds to get 3 visits.
We take care of our hair. We take care of our we spend more money on
Think of how much people pay, and especially in LA. Dear God, I have a friend that's a hairstylist. She makes more than me. I'm like, this is crazy.
Yes. And the quality of life that gives you. So
exactly.
All right. So what are some of the risk factors with having increased pain?
So I think if you're talking about specific to postpartum, a risk factor for having painful sex postpartum would be having painful sex before getting pregnant, which is also another myth that's talked about, you know, perpetuated by physicians a lot. In my patients that have vaginismus, they were told that if they have a baby, that will cure their vaginismus. And I'm sure you've heard that too, you know, and so when in fact multiple research studies support that having pre-pregnancy pain increases your chance of having post-pregnancy pain. Breastfeeding also, again, the hormonal changes we talked about. You know, other risk factors I would say that I don't necessarily have a study to point to, but I just see this clinically. If they have like back or hip pain, like that can drive pelvic floor dysfunction or sexual pain. Having obviously any sort of trauma to that
history of abuse or
and abuse might not even be like a sexual abuse. Like it could be some other trauma, like maybe they just had a traumatic first pap smear, right? Or you know, maybe they had a thick hymen or like one of those hymen variations where there's like almost like the perforated hymen, or a septate hymen where there's like the sort of thick band that goes down the middle of the vagina. And when that tries to tear, it can be very painful. So they might have some sort of like hymen issue that's contributing to their pain. And however, though, when I've had patients with that history and they and they have a hymenectomy and they just have that expectation that that's going to take care of their pain, but they have all that muscle guarding. So it's the same thing as like the breastfeeding. Like it started for one reason, but now the reason you still have pain is for a different reason, and you need to address that. Other things in their history are commonly things like urinary tract infections, yeast infections. With yeast infections, it could be the infection itself, and UTIs. Because muscles will guard around areas of pain or discomfort, so muscles can get stuck in that state. But it also might be history of, maybe like an allergic reaction to something, like maybe it's a detergent.
Like some kind of inflammation or something.
Yeah, or, you know, they had a yeast infection, they used like a cream and they had an allergy to the cream, for example. So maybe it was an allergic response that sort of perpetuated their vulvodynia or created their vaginismus. And, you know, there could be nerve injury, right? Like that can happen in various ways, like landing on a bicycle seat really hard, or like birth trauma. So there's a lot of different reasons that people might have pain, and none of them are them being crazy. None of the reasons for them having
it's not their fault.
It's not a psychosomatic pain. And talking about it is not going to get rid of it, although I do encourage a lot of my patients to incorporate like a psychotherapist in their care if they don't have one, or a sex therapist to help with like intimacy issues. But they need the physical addressed.
So segueing into that, my next question, can you explain what an oasis tear is and what are the implications relating to sexual function? How will that kind of tear affect sex?
Right. So oasis tears are obstetric anal sphincter injuries. And what that means is it's something that occurs with a vaginal delivery. And great. Thank you for having a pelvis.
Yep.
You can have different degrees of tearing from like 1 to 4. So an oasis tear would be a 3rd or a 4th degree tear. And a 3rd degree tear is, it goes through the perineal muscle layer that's the one going down towards the anal canal. So, but it doesn't go through the anal sphincter.
Stops right there.
Right, or to the anal sphincter. And then the 4th degree tear goes through the anal sphincter and into the vaginal mucosa. And actually, I should say the 3rd can go to the anal sphincter. So I think I missed
right.
when
Yeah,
I
right to
said
that
that
edge
before.
there.
And then the 4th degree goes through and then into the anal mucosa. And so what that means for both of these types of injuries is it increases their risk of bowel dysfunction, bowel incontinence, which is like really the dirtiest kind of incontinence. It's the hardest to hide. Like that smells. A little bit comes out and
you just feel awful.
And so it's very socially distressing to people intimacy wise. It's not going to make you feel like you want to have sexy time when you have that bowel smell. So it can have a huge impact on that. But then also because of the severity of the tear, you'll get a lot of scar tissue. So, one of the things that we look at postpartum after vaginal delivery is like scar tissue sensitivity. And is that an issue and contributing to their pain? One, like the sensitivity of the scar itself, or is it really thick, like a keloid type scar that could be causing a lot of like sort of closure on the area and pulling on the muscles? So there might just need to be stretching, like maybe the scar itself isn't sensitive, but it's causing so much tension from the way it healed on the muscles around it. But as we know, like scars can remodel and we can work on them and we can desensitize them and we can get them to be less restrictive so that doesn't become a reason they're having pain.
Good. Yes. Excellent. Okay. So what would be a standard treatment in your facility for someone coming in with painful sex? What could they expect?
So I'm a huge fan of dilators, and I use dilators for a couple of different sort of purposes. One is to make mechanical change in the muscle. So doing specific muscle release techniques that would be very similar to like if you went to a massage, like for your neck or back, like they'll do those tender point releases. They'll do different like directions of strokes to try to get that muscle to like unlock and release. So exactly. So I have in my book, I outline like several different techniques that women can do to themselves. And we also in my office instruct them how to do that as well. And it's so that's sort of one part of it is like the mechanical change. And then also teaching them how to move through larger dilators to work towards their sexual function, so with the goal being something that's closer to their partner's size. So starting with something, I love that extra small dilator that becomes sort of like their core program and can also help them because we see people who have painful tampon insertion as well. So making sure that they meet that goal, and then they get really motivated when they start moving up to larger and larger dilator sizes, getting closer to their goal size or their partner size. And the purpose is always to be pain-free with insertion and with movement. I don't put patients on a timeline as far as like, okay, it's been 2 weeks, time to move up to the next size, because our bodies don't work like that. So they move up when their body is ready to move up and their mind is ready to move up. Those have to match.
Good.
Those have to match. And then also I'll use dilators for desensitizing. So that would be more for people that have like just certain areas of hyperirritability, perhaps like the like maybe scar tissue sensitivity or like peripheral nerve sensitivity. And, that's just can happen through movement of the dilator as well. But there's a couple different reasons they use the dilators. But when I'm in the session with them, and my book also only talks about the muscle part, because it's easiest for patients to understand that. They get it. They have muscles elsewhere in their body. They've had massages elsewhere in their body. They get it. And I'm trying to simplify, not overwhelm.
We're trying to connect with people and help them get help.
Exactly. Exactly.
Good. Yes. So then what is the, before I mentioned your book, just remember it's on Amazon. It's called Sex Without Pain. So it's well worth every penny. So I encourage, if you are a provider or if you have pain, get this book. Okay. So what is the typical time frame that women can expect to be pain-free if they're having painful sex? Do you have a typical time frame?
Yeah, I mean, it's a typical time frame, but it's a broad time frame because it depends on many factors. It depends on how severe they are when they come in. It depends on how compliant they are with the home program. Yes. It depends on how often they're coming in and seeing us, plus doing their home program.
It's not a magic pill that they can take.
It's not a magic pill. It does take work, but it's good work that is temporary. You know, like you give a little bit of time now to help yourself in the future for the long term. But when patients call and they ask that question, I tell them most people fall within 4 to 8 months. And, it's a big time frame, but if I haven't seen you, I can't give you a shorter time frame than that. I've had patients that have been pain-free in less than 6 weeks. And I mean, that was even a couple of them could not even put in a tampon without pain. So it's not like they were starting like only not able to get their partner size in, but anything smaller. Like, no, these people are starting off very severe. And I think when they don't have maybe other things driving it, like hip or back issues,
it can be easier to isolate it and address it. Yeah.
Yeah, well, they just are like, I don't really have any hangups. Like, I just have this issue. They can just like power through, and their body's like, oh, that's all I needed to do. Like, why didn't someone tell me that 5 years ago? Like 5 years of, unconsummated marriage is like, so 4 to 8 months is typical. And then some people might take longer. And the ones that would typically take beyond 8 months are not only severe in presentation, meaning like even a tampon is impossible or very, very painful. But also there's usually some sort of other trauma behind it. And there's a little bit of that like psychology that's influencing their pain. So those patients can often take over 8 months. Or if they're having painful sex when they have endometriosis, they are typically very long-term patients because they have some constant inflammatory internal driver that is just there. So, we get them calm down as much as we can, both with their pelvic floor muscle down training or relaxation, as well as like their nervous system. And, whether or not they're planning to have surgery or they're post-operative, but we just try to be a long-term support for them because a lot of them do better when they just have ongoing care. And when they're stable, it's not weekly, it's maybe once every 3 to 5 weeks. They're coming in for a recheck. They're still doing their stuff at home because, it's just something that they have to manage. It's kind of like once you get a herniated disc, like you just kind of always got to be a little bit more careful with how you lift things because you don't want it to go back to where it was. Right. So with every patient, I always give them like a standard orthopedic equivalent because I want them to understand that these are just normal parts of the body that we're working with. They respond just like any other muscle would respond, and there's no reason to have shame around it. We just have to normalize that conversation with them and equaling it to like a back injury or a neck injury, I think patients get, and they really appreciate because then it gives them comparisons that they can talk with their partner or their friends about if they choose to share.
Mm-hmm. Very good. Is there a window of time when you would say that it's too late to help someone?
No.
If you're sexually active.
No, not at all. So I had a 19-year unconsummated marriage. She now has a 6-year-old daughter.
Hey, it happened.
And it wasn't from IVF. It had sex. Spoiler alert.
Yes.
19 years unconsummated marriage, a history of trauma, the whole deal. And she was my longest patient for someone that did not have endometriosis, someone that was strictly like trauma associated, pelvic floor isolated condition, a little bit of low back pain, but I didn't feel that was the reason she was having pelvic pain. It was more due to her other history. But 19 years, unconsummated marriage. You couldn't even use a tampon. It is never too late. Never. Your body will always respond.
Good. What are some of the common myths? And in your book, you have a common myth section.
Yes, I do. I have, and whenever I do a volume 2, like I have so many more myths, the things patients have told me.
Yes.
Okay, so here's a good myth. Having a glass of wine will cure your vaginismus. Nope.
No, and that's so offensive, really.
It's offensive,
and especially if it's still being given. That is.
I still hear it. I got patients in their early 20s, and that's what their OBGYN told them. So this is medical advice that's given, and it's appalling. So alcohol is not a cure for any pain anywhere in your body. Just like if you went to your orthopedic surgeon and were complaining of back pain, if they told you to have a shot of tequila, I'm pretty sure you would turn around and leave. So
yeah,
so alcohol will not cure vaginismus. Also, having a baby does not cure painful sex. We talked about that earlier. So that's a common advice that's given to patients. But don't even know how they're supposed to get pregnant if they can't have sex. It's very expensive to do so, if you're not having sex. So you're
exactly
signing up for a huge financial commitment on a gamble.
Exactly.
Yeah. Other things I've been, patients have been told actually that they have an STI, even though all the tests have come up negative, because they have burning pain. So patients or doctors will say, like, you have like a post-herpetic neuralgia in patients that don't have herpes because they have vulvar burning. So patients like freak out because, you find out you have herpes and you're like, what? Like, I've never had sex. How do I have herpes? So they just are all these things that are given that don't match their history. So those are some sort of problem myths that patients have been told. And also, just the running thread of wait and see, like the myth of
it'll get better on its own.
It'll get better on its own. Just wait. Because it does. Sometimes it does. A lot of times it doesn't. So you're just gambling with your own body and your relationship if you wait and see.
Mm-hmm. And I think something else that's important to remember too is that it's not in your mind. So, right, there's physical changes that are occurring and they can be addressed with a pelvic therapist. So
yes, exactly.
There's hope and help.
Exactly. And pain is and this is pain talk would be a whole separate line that we can do. But in short, pain is more complicated than is processed at like our periphery. So pain isn't processed at the vulva. Like you feel it maybe at the vulva, but all the processing happens in the brain. And it's very complex. And because of the way our brain is arranged, so if we do this again and talk about the brain, I'll like get my little models out that I show patients because I am at home right now, not in the office. So I don't have those handy, but we have like overlapping, our nerves overlap in our brain. So it can make other areas start to hurt, even though it wasn't the primary area that was hurting. So the intra-abdominal area in the brain is right next to like the pharynx, and leading up to the jaw area. So one of the most common concurring chronic overlapping pain conditions with pelvic pain is TMJ dysfunction.
I know. I'm trying to not tense while you're talking.
Yeah. And one, why do we hold stress here anyways, but in the brain, like you look at the sort of the neuroscience part of it, those regions overlap, and our brain is not like, oh, my intra-abdominal area end and my neck and jaw area is beginning. There's overlap. And so one area will start to make another area hurt. And doctors, a lot of them they think they forget their basic neuroscience. And so they really, shrug their shoulders and dismiss patients. They're not sure why they have that pain. But if you look at the anatomy, that's why women have that pain for one reason. There's more other complex reasons for pain, but it is all processed in the brain. And, women need to understand, though, that just talking about it, though, like a psychotherapist, it's not like a cognitive behavioral therapy that they need, even though there's central processing or brain processing that's sort of not in sync with what it should be. You can't only talk away chronic pain. Like you couldn't talk away back pain. You can't talk away pelvic pain or sexual pain.
Yeah. Good. Excellent. Okay. So now we're going to jump into a few of the audience questions.
Okay.
All right. So, 4 months postpartum, will my episiotomy site ever not feel pinchy when pressure is put on it? So there's 3 questions on here all about scar tissue.
Yeah, so she might have some scar tissue sensitivity, and yes, it will, but she needs to learn some desensitization techniques. So that's something that a pelvic floor physical therapist can teach her how to do. And it could also be pulling on the muscle. That might be some reason that it feels pinchy, or there might be some fascial restrictions in the area. But all of that, between like dilator and skilled manual therapy, by a licensed pelvic PT, can address those symptoms. And that sounds, if that's her main issue with postpartum, then that shouldn't take much time.
Yeah,
you know,
that's
like
encouraging, really.
Yeah, if I had a patient like that and that was their only complaint, I would tell them probably like 3 visits, you'll be good. Like 3 visits over a month period, and you'll be good.
Yep. Okay, so this is something I hear a lot because we're advocating pelvic therapy, but even in the U.S., there are pockets that it's just not accessible, or you may not have the resources. Okay, so what would be your next step with this if she doesn't have the resources or the access to a pelvic therapist?
Well, my book, yeah.
There you go. That's good.
And even though it doesn't,
I want you to plug it because we want to give people, and it's Kindle. It's available on Kindle and paper, right? So
yep, exactly. On Amazon in print form and Kindle, and then if you don't like a PDF immediately, sexwithoutpainbook.com. You can get an immediate PDF download. So I don't specifically go over postpartum or scar tissue techniques in there, but doing the musculoskeletal program will help desensitize that scar tissue and help remodel it, because I do have a technique in there called a perineal massage that is a technique that we use in office to address scar tissue pain. Hi, you're back.
You know what? I forgot to put do not disturb on this. And so that was the call that was coming in. So, sorry. Hopefully that doesn't happen again. We're close to the end.
Okay. Yeah. Did you get my whole answer?
So yes, the perineal massage. The book and the book goes over the perineal massage. Yeah. And then we also, there's a lot of resources on Instagram of different tips and techniques in terms of perineal massage. But check out her book because it gives you some really structured step-by-step guidance. All right. What do you do about internal anal pressure with penetration? So there's so many questions about that, like what position, what things are going on, but what would you initially say for this?
Well, yeah, and is she talking about, did she say vaginal penetration?
Well, she didn't say, she didn't specify, so I'm not sure. Let's say vaginal. She's having anal pressure with vaginal penetration.
So a couple questions I would follow up with is, does she have issues with constipation? Because maybe the pressure is coming because there's stool stored in the rectum. And so if you have chronic constipation, that's going to create a lot of pressure.
Those canals share a wall. They're right
next to each other. There's only so much space in that area. And if you're like, you have constipation issues, you're going to limit that space. The other thing I would check would be her levator ani muscle, because a lot of patients, without intercourse, they'll just experience like a feeling of like a ball in their vagina or a ball in their rectum or a pressure in their rectum. And a lot of time that's because of levator ani muscle overactivity. So I would check and see if palpating that reproduces for pressure. And if so, then I would have that sort of be part of my focus treatment area. So she could have, or she might have both things going on. Maybe she's constipated and she has an overactive levator. I mean, one of the levator muscles is the puborectalis, which slings around the back of the rectum. So she might have some pelvic floor dysfunction there, between maybe a hard stool, but also some dysynergia or some incoordination of her pelvic floor muscle function. So she might need some down training. She might need some coordination retraining to get that straight.
Good. We're going to try to get 2 more questions in. Is it normal to hurt if you've never been sexually active?
That's a great question. I would say it's never normal to hurt. I would say there's always a reason that you have pain. So for the first time, if a woman has hymen that's particularly thick or has one of those hymen variations I talked about earlier, it would be likely that it would hurt, but I wouldn't say that it's like normal. It's just, I have a problem with that. So
I know that word.
They ask that. And if it's a one-off, then okay.
Yeah.
But if it continues to hurt, then for sure you need to seek care because, you know, okay, there was the reason you had the pain, but that reason's gone now. And why are you still having pain?
Yeah. Good.
I don't really like the normal the first time. You know, maybe you weren't aroused, so, you know, that could be an issue to be explored. I would just say there's always a reason you have pain, and maybe don't be so worried about it the first time, but if it happens a second time and ongoing, then you need to explore why you continue to have pain.
Yeah, good. And then lastly, my vaginal cavity, I'm thinking canal. Vaginal canal is angled toward the back. Any advice?
Well, everyone's vaginal canal is angled towards the back, so good.
It's normal.
Yeah, if I had another diagram of that, or in my book, actually, you know what? I do have a copy of my book here. I have a cross section of that if I can pull it up real quick.
Yes.
So that she doesn't feel she's abnormal.
Yes.
But that's what it does. It dives back towards the sacrum, like towards the tailbone area. And so here we have a side view. We have the front of the body. Where am I at? Like belly button will be here, spine and sacrum here. So let me put her on her back.
Yep.
Okay. There's the vaginal canal. Whoop, towards
Look at how angled it is.
Yeah. So you're good.
I love it. Yes. Yes. Good deal. Okay, so anything else that you'd like to share with people before we go?
Just know that if you know you have a problem, don't let your provider dismiss you and make you wait to get that problem addressed. In a lot of states, physical therapists can actually be accessed directly by bypassing their physician, but each state has different rules. Sometimes you can only be evaluated. You can't be treated without a physician prescription. And even though doctors dismiss their patients, a lot of times they'll still approve the physical therapy. You know, so if you're in a state where you can only be looked at but not treated, your doctor will probably still sign it once the PT sends their report because it's not going to hurt you. I mean, I think they got to be pretty off their rocker to be like, oh no, you just don't need that. I'm not going to sign that. I mean, it's time to find a new doctor if you have somebody that resistant to you wanting to get care for your problems that you know there is treatment for. So always be an advocate for yourself. I know you shouldn't feel like you have to be an advocate for yourself, but unfortunately you do. And just, you know, now you have a little bit more knowledge, hopefully, and some vocabulary and some understanding about why this therapy is so needed, because it's just not, these are problems that are just not going to go away. So advocate for yourself.
And if you're a provider out there, ask. Ask the question.
Yes, ask the question.
The patients may not bring it up.
They usually won't, actually. That's what the research shows. But providers don't ask because they don't have the time to get into that conversation. What if the person says yes?
Yeah, I know. And they may not have the resources. They may not know all the resources too.
So you can educate your provider as well.
Yes. And if you need anything from us, if you need research, if you need links to different things, we're accessible. So thank you. Thank you, Dr. Jeffcoat, so much for your expertise. I can't imagine how much time and love you put into writing this book, but I want to say thank you. I share it as much as I can, and it's an amazing resource, and I really appreciate that you've done it. And it's available in Spanish too, correct?
It is available in Spanish. Yeah.
All right. Good deal.
Sin dolor.
Hey, and that's on Amazon as well, or on your Sex Without Pain?
PDF on Amazon. Not PDF. On Kindle only. It's not in print. Or you can get the PDF download also.
Good deal.
On that website.
Okay. Well, thank you so much for joining us. Everybody here, thank you for joining us today. I really appreciate your time and your feedback.
Thanks, Denise.
Yes, and this will be available on YouTube probably within a week or so. So our YouTube channel is My Pelvic Floor Muscles, No Spaces. All right, everybody.